when these patients with diastolic dysfunction and they have to undergo anesthesia, what are our perioperative concerns while anesthetizing these patients? So do they really carry a high risk? Yes. There are a lot of articles, lot of research have been done in this. They all are clearly showing beyond doubt diastolic dysfunction is an independent predictor of postoperative morbidity, especially for events like postoperative cardiovascular events, as well as even in the ICU, they are considered as one of the independent predictor for failed weaning trials. So now, having understood the impact of the diastolic dysfunction on these patients who are going to undergo surgery. So what is going to be your goal, or what are the things which you need to understand, you need to assess during the preoperative evaluation? What is your aim? So as I have already told that these patients are often asymptomatic at rest, it is our duty to identify the patients who are at risk. There are certain group of population who are at risk. Number one, female gender, or age more than 70, or if there is a history of untreated hypertension for a long time, or history of coronary artery disease and diabetes mellitus. All these conditions are risk factors for the patients to develop diastolic dysfunction. Number two, since these patients are asymptomatic at rest, that means only when they are undergoing certain stressful condition, they will exert signs of heart failure. So you have to ask for clinical signs of heart failure, intolerance to exertion, or patient developing breathless on walking. Here, this is where our assessment of the functional reserve plays a major role. Then other factors carrying high risk for diastolic heart failure, you have to look for those conditions like any other arrhythmias. That is, especially the atrial arrhythmias plays a major role because these patients are dependent on atrial kick. Then finally, these patients have to be assessed by using, once you identify the risk group, it is mandatory to assess these patients for diastolic dysfunction by help of echocardiogram, then looking for any changes in the morphology of left atrium or left ventricle, is there a left ventricular hypertrophy, or how to assess the diastolic function. That is what we are going to discuss in the next few slides, and most importantly their systolic function also. Okay. So having said that, these patients, this is very important, these diastolic dysfunction patients are always asymptomatic at rest. Only when their cardiovascular system is stressed, it gets unmasked because they do not have adequate physiological reserve. They cannot increase their end diastolic volume under stress because the chamber is already stiff, which leads to reduced stroke volume. So as a result, these patients, especially those who have got subclinical diastolic dysfunction, will easily pass through the preoperative evaluation, but only to decompensate in the operating room when they come across any unfavorable stressing conditions. So we need to pick them during our preoperative evaluation itself. That is the goal of our pre-anesthetic evaluation. Okay. So how are we going to assess the diastolic dysfunction? Even though the cardiac catheterization is the gold standard for measuring the values, because you know that it is an invasive procedure and it needs a lot of expertise and it is not available everywhere. So the echocardiogram is the basic and single tool to assess diastolic dysfunction. It is available everywhere, and expertise, as far as the expertise is concerned, we all are very much familiar with using the ultrasound nowadays. So why can't we extend our expertise into doing this transthoracic echocardiogram? And we need to know how to do POCUS, the various lung ultrasound, gastric ultrasound, so many areas we have been increasing our expertise. But so that it is our duty for every anesthesiologist to learn how to do an at least transthoracic echocardiogram. It gives you a lot of information about the patient's cardiac reserve, not only about the diastolic function. So it's duty for every one of us to know doing basics of cardiac ultrasound. Okay. So what are we going to do? How are we going to assess the diastolic dysfunction using this transthoracic echocardiogram? It starts with assessing the global morphology, both LA and LV, to find out whether the LA has got it's enlarged, is there any remodeling has happened, or is there a LVS, something like that. So once it is done, how are we going to assess the diastolic dysfunction? There are a lot of echocardiography tools are available, like transmitral inflow pattern assessment, tissue Doppler imaging, pulmonary venous inflow, and color mode propagation. velocity. But as a cardiac or a non-cardiac anesthetist, it basically, if we need to know, these two are very important: transmitral inflow techniques and tissue Doppler imaging of mitral annulus. So how are we going to do this? So what is this transmitral inflow pattern? It is nothing but we are going to analyze the flow using the Doppler velocity signals. This is a mitral valve, as you all know. This the flow is going to happen from the left atrium to left ventricle. So if you are going to analyze the flow velocity at this level, this is going to reflect the pressure difference between the left atrium and the left ventricle. And if there is any abnormality, this flow velocity will be picked up. Okay, so let me explain how to do that. This is an apical 4-chamber view. This is the Doppler signal. This is the gate sampling. It's usually advised to keep the sample volume from 3 to 5 mm. And this is the mitral valve. Keep the sample volume just at the opening of the mitral valve. Okay, let me show this video how to do that. See, now once the sample volume is placed, when the Doppler is activated, it is going to give bifid waves, something like this. So there are going to two waves is going to be generated. So just like earlier I have said, first wave represents early filling and the second wave represents atrial contraction. This is what is going to is being generated here. The first one is the E wave, early filling. It denotes the passive LV filling, and the second wave is the A wave, which shows the active atrial contraction. So how are we going to interpret this E and A? So first, what is the maximum velocity this both E and A have achieved? So normally we know that majority of the or major part of the filling happens during the early period. That means E is always taller than A. So E by A ratio is normally more than 1. So this is normal. During the normal diastolic function, E is always higher or E is always more than A. But what happens when the diastolic dysfunction sets in? Let's see. So it is reversed. You see, the bifid pattern reverses. That is, E is small and A is bigger. Why it is so? Because in order to maintain the transmitral pressure, the atria compensates. Because we know in grade 1 the relaxation is impaired, so that atria generates more pressure to push the blood from the left atrium to left ventricle. As a result, your early filling comes down and the late filling that is being contributed by the atria becomes more. So your E by A ratio becomes lesser than 1. This is how a grade 1 diastolic dysfunction behaves. What is grade 2? As the disease progresses, what happens? The compliance of the LV is reduced further. As a result, LA remodels, left atrium remodels, and pressure progressively increases to maintain the transmitral pressure gradient to push the blood from left atrium to left ventricle. As a result, your normal transmitral pressure gradient is re-established. So that means again the early filling takes the precedence. The majority of the flow happens during the early filling and the atrial atrial kick contributes only 25%. That means again this goes back to the normal pattern. This is called pseudo-normal because you cannot differentiate a normal diastolic function from the pseudo-normal pattern. That's why it's called pseudo-normal. So this is one of the pitfall of this transmitral inflow technique. How to avoid that or how to overcome this, we'll see in the subsequent slides. So what happens is, see, in the grade, this is what this is what I have already told. In the normal situation where blood is being sucked because of the negative pressure that is generated inside the left ventricle, it opens up the mitral valve and it just sucks the blood from the left atrium. Whereas when the diastolic dysfunction sets in, because of the impaired relaxation, the left atrial pressure starts increasing. As a result, left atrium, it's something like its blood is being pushed from the left atrium to left ventricle. That is the difference between a normal pattern and a pseudo-normal pattern. So what is restrictive pattern? So as the disease progresses, stiffness is increasing. As a result, LA pressure increases furthermore and because of this high pressure gradient across the mitral valve, once the mitral valve opens, blood gushes inside. But what happens, because the left ventricle is already stiff, this pressure gradient dissipates very fast, and because the pressures equalize very fast. As a result, it produces a tall, narrow E wave, which is little bit, even compared to other E waves, it is narrow and it is as well taller than the A wave. So the ratio becomes more than 2. This is called a restrictive pattern. So this restrictive pattern can be reversible if you are using some preload reduction technique, especially Valsalva. If this situation, this restrictive pattern turns into a pseudonormal pattern, then it is called reversible, and by using Valsalva, even after using Valsalva, if pattern is not reversible, it's called grade 4, irreversible. So basically this is what is the wave, different waveform, how it is produced. In normal, always E wave is bigger than the A wave. In the impaired relaxation, that is grade 1, the E wave early filling goes down and atria compensate. As a result, A wave becomes bigger. During the pseudonormal, again the transmitral pressure gradient re-establishes and early filling takes place. More filling happens during the early period. E wave becomes taller again, just like the normal. And during the restrictive pattern, E wave becomes very narrow and very tall. Okay, so it is a simple technique, yes, but it has got a lot of pitfalls. So this transmitral inflow pattern are affected by the loading conditions, and as I already told you, it cannot differentiate a pseudonormal from the normal pattern. And in the presence of arrhythmias, especially arrhythmias, because you need to study both E and A waves. If the A wave is absent, you cannot quantify the E wave velocity, and in case of mitral valve abnormalities also, we cannot study this transmitral inflow pattern. So what are we going to do? This is where the second technique, that's a tissue Doppler imaging technique, comes into play. So in the earlier study, we are using the Doppler signal to study the high velocity signals, that is the blood flow. So here, by using a low velocity signals, we are going to study the how far the movement of the tissue. When we say about tissue, what tissue? Here we know that during the relaxation, that is the diastolic phase, there is going to be a longitudinal movement of the left ventricle. It is going to get pushed down. So if you are going to analyze the movement of the mitral valve annulus, both at the septal as well as at the lateral annulus, we can quantify the movement of the relaxation. That is the concept of using this tissue Doppler imaging. So here, instead of placing the Doppler signal here, we are going to keep the sample volume at the annulus, either as a septal annulus or the lateral annulus. Make sure that your tissue Doppler imaging is on. So when you do that, what happens? Let me show. It produces a spectral waveform. So same E, A and S waves are generated in this, but it is in the opposite direction. So here in the transmitral inflow technique, we have seen the E and A in the above the x-axis. I am talking about the transthoracic echocardiogram images. It may be different in the TEE. These images are captured in the transthoracic echocardiogram. So that point you have to remember. So in the transthoracic echocardiogram, in the tissue Doppler imaging, both E dash, we call it as E dash or E prime, happens at the below the x-axis, and this is the S dash. Again I am repeating, this is E dash or E prime, A dash or A prime, and S dash or S prime. But what is more important here is, in this tissue Doppler imaging, we are going to study this E prime or E dash waves. So what information it is going to tell us? This E prime corresponds to the velocity of the relaxation of the left ventricle. Okay. So unlike the blood flow velocity that is happening across the mitral valve, this tissue velocity, they are less susceptible to loading condition. That is an important point to be remembered. And it does not normalize in the pseudo-normal state. That is a second important point. So recent guidelines say that if the E dash is more than 10 centimeter per second, you can confidently say that this patient does not have any diastolic dysfunction and further investigation is unnecessary. However, if the E prime is less than 10 centimeter per second, then grade the dysfunction by using transmitral inflow techniques by getting an E wave and go for the E by E prime ratio. So what is this E by E prime or E dash ratio? So this concept you need to understand. When we do the E wave, that is a transmitral inflow technique, we are assessing the pressure difference between the left atrium and the left ventricle. So that means E denotes the pressure and E prime we are assessing the increase in the left ventricular volume. So E prime is the volume. So E by E prime represents the relationship between the LV pressure and volume change, means elastance, pressure over volume, and the reciprocal is going to be compliance. So if the E by E prime value are higher, that means the compliance is less and the likelihood of diastolic dysfunction is very high. This is a concept of utilizing the E prime as well as E by E prime ratio. So we can confidently say if the E by E prime ratio is less than 8, your filling pressure is normal, and if it is more than 15, the filling pressures are very high. 8 to 15 is somewhat called as what is called as indeterminate area. Okay. So we can calculate the E by using this E by E prime ratio, we can calculate the left atrial pressure. Also there is a formula called Negev formula where 1.2 into E by E prime plus 1.9 gives an approximate value about the left atrial pressure. So to summarize this, whenever you do a transmitral inflow technique, if the E by A ratio is less than 0.8, it tells you about the patient has got grade 1 relaxation failure, that is diastolic dysfunction. If it is between 0.8 to 1.5, because more than 1 is normal, it is called as pseudo-normal, in which situation we have to do this TDI and find out what is the E prime, and if the E prime is more than 10 seconds, that is the lateral, or if the septal E prime is more than 7, the diastolic function is normal, or if it is otherwise, it's a grade 2. We can confirm it is not normal, so it is the grade 2 diastolic dysfunction, and if it is E by A ratio is more than 2, it's grade 3, that is the restrictive pattern. So once these patients are coming to surgery, what are going to be our perioperative goals? The main aim is to prevent these patients, that's the diastolic dysfunction patients, to develop from diastolic heart failure. So how are we going to achieve this? So we know that these patients are asymptomatic at rest only when they are undergoing or when they are exposed to the stressful condition and they get unmasked and land up in diastolic heart failure. So this stressful condition, we have to identify what are these stressful condition and avoid that perioperatively. To start with, the most important one is the tachycardia, followed by blood pressure control. But always make sure that your diastolic blood pressure never goes below the pulse pressure, and the maintain sinus rhythm and judicious fluid strategy. And finally, these patients don't behave like all diastolic dysfunction patients. They don't behave in all the same patient. So that means, so grade 1 patient will behave separately, differently. Grade 3 and grade 4 patients behave separately. So we need to have a tailored approach for each degree of dysfunction. Okay. So having said that, what are the different stressing conditions we have? The first and foremost is the tachycardia, because we know that whenever there is a tachycardia, it preferentially encroaches on the diastolic period. As a result, the time available for the relaxation is less and it is going to impact the filling, which is going to increase the left ventricular end diastolic pressure. The next one is the hypertension. So both hypertension as well as the hypotension is going to cause problem. In case of hypertension, it increases the LV wall tension and it leads to impaired myocardial relaxation, pushing the patient into diastolic heart failure. Then ischemic episodes, which we have already seen. Because the diastolic function is an energy consuming process, if there is going to be an ischemia, it's going to cause impaired relaxation, pushing them into the diastolic heart failure. Then alteration in loading condition, whether it is a preload or after load, these patients they will be unable to compensate any increase in the left ventricular and diastolic volume. So whenever you are using the fluid, you have to be very careful. And finally, the atrial arrhythmia. Because these patients are dependent on the atrial contribution, any atrial arrhythmias is going to push them into diastolic heart failure. So to start with, the rate control is the single most important strategy you need to have. Always maintain the heart rate between 60 to 70 because during the tachycardia, it is, as I already told you, the diastolic period is reduced. So what are we going to do is consider rate control agents such as beta blocker, calcium channel blockers or dexmedetomidine like alpha 2 agonists. The second important point is the sinus rhythm. So these patients are dependent mostly on the atrial contraction. As a result, any atrial arrhythmias is going to have immediate and pronounced effect. So what are we going to do is make sure that it is recognized at the earliest, and you should have a lower threshold for doing cardioversion than in the patients without diastolic dysfunction. So blood pressure control, always try to maintain the blood pressure within 10 to 20% of the baseline. So here this is what the rule of 70 will be whole good. What is this rule of 70 is diastolic dysfunction is very common in the patients aged more than 70, and diastolic blood pressure should be always maintained above 70. Pulse pressure should be less than 70. That means the diastolic blood pressure should be always above the pulse pressure and heart rate around 70. So as I already told you, each group of, that is grade 1, each grade will behave separately, and we need to have a specific plan for individual patient. That is, the patients with grade 1 diastolic dysfunction, our main focus is on increasing the diastolic filling time, because here we have to make sure that they have adequate preload. So avoiding tachycardia takes the precedence, or is the most important point here. At the same time, these patients, grade 1 patients, are dependent on the atrial contraction. So sinus rhythm also has to be maintained and maintain the preload adequately. Whereas grade 2 diastolic dysfunction, they are more challenging, because here their left atrial pressure is already high. They will be less sensitive to the loss of atrial kick, but they are more sensitive to the fluid status and can have a dynamic physiology. Means if their fluid is on the lesser side, they will behave like a grade 1 dysfunction, and when they are volume overloaded, they may progress to the grade 3 diastolic dysfunction and behave accordingly. So whereas grade 3 and grade 4 are restrictive pattern, or they carry a very high perioperative risk because their left atrial pressure is always elevated, persistently elevated. So any change in the fluid, that is fluid overload, or any change in the hemodynamics, makes these patients susceptible to develop pulmonary congestion. So when these patients develop something like a diastolic heart failure, it's better to start the vasopressor and the ionodilator therapy as a first line rather than relying on the volume, because the therapeutic window for the fluid management is very notoriously small for this group of patients. So coming to the technique, what technique is beneficial for these type of patients? Even though researchers have not pointed one technique over the other, each technique has got its own advantage and disadvantage. If you are planning for the general anesthesia with controlled ventilation, make sure that your induction is very smooth, and remember, most of the patients are going to be very elderly. So always titrate the dose. Most of the patients may take only 30 to 50% of our regular induction dose, and also since they are very elderly, they do have a slow circulation time. As a result, you wait for the effect. Do not keep on repeating the dose. And the smooth bag and mask ventilation transition from your induction to bag and mask ventilation should be smooth, because it is better to start little early, because you have to avoid hypoxia and hypercarbia, and most importantly, the intubation response has to be taken care. Either by using a beta block like esmolol or dexmedetomidine can be used to make sure that rate is under control. So if you are planning for regional anesthesia, it's not directly or it's not strictly contraindicated, but you have to make sure that there is not going to be any rapid changes in the hemodynamics. In that context, epidural is preferred over the spinal anesthesia, but at the same time, make sure that most of this patient will be on anticoagulant medication. So necessary modification have to be done if you are planning for the regional anesthesia in this group of patients. So what about the effect of anesthetics on diastolic functions? Even though the earlier animal studies are showing some detrimental effect on the diastolic function, but recent human studies, they are not showing any detrimental. They show that present day inhalation agent, that is sevoflurane, isoflurane and all, they do not have any detrimental effect on the relaxation. But there are not much studies done about the intravenous induction agents on diastolic function. but it has been shown in fewer studies ketamine has been shown to decrease the LV compliance, and propofol is known to prolong the isovolemic relaxation time, but they do not significantly worsen the pre-existing diastolic dysfunction. Maybe a lot of other studies are required in this area. So what about the monitoring? Apart from standard monitoring devices, do we need to employ a special monitoring for these type of patients? Yes, maybe it depends upon not for all the patients, may be required for more complex patients, especially if the complex surgeries involving the large fluid shifts, because it helps you to assess the perfusion of the end organs as well as to assess the volume status. Whereas central venous pressure monitoring, we all know that it is not a good monitor to predict fluid responsiveness. So if at all, if you want to have a central venous line, it's maybe used for administration of the medications such as vasopressors and inotropes in case if you are going to use them. So but the single most tool is the echocardiogram. So the question here is, which is better, whether it is a TTE or a transesophageal? Yes, transthoracic echocardiogram is a better tool to analyze this patient preoperatively, but intraoperatively transthoracic echocardiogram has got its own limitation, because most of the major surgeries where the larger fluid shifts are happening, where you need to monitor the patient intraoperatively, involve the surgeries involving the abdominal or chest cavities, where you cannot use the transthoracic echocardiogram. So TEE may be beneficial in the intraoperative period. So what are the information we are going to gain from this? So as I have already told you, mitral inflow patterns and tissue Doppler imaging. So by doing that, we can know what exactly is the diastolic function or what grade of the diastolic dysfunction the patient is at present, whether the patient is worsening or whether the patient is improving. And also you can assess the left ventricular function. Most importantly, the volume responsiveness. Whenever the patients are developing some signs of failure or some hemodynamic instability, the question that comes to our mind is, how much fluid are we going to give? Should I give more fluid or have I given enough? So this question can be easily answered if you have TEE in the hand. So for some reason, if these patients develop into the diastolic heart failure, what are we going to do is, our main aim is to improve the relationship between the left ventricular end diastolic volume and left ventricular end diastolic pressure. What are we going to do? How are we going to do is by controlling the circulating blood volume, because we know that even a small reduction in the left ventricular end diastolic volume can lead to a marked decrease in the left ventricular end diastolic pressure. So how are we going to do that? There are two methods, either you can use nitrates or diuretics, but in this situation nitrates are preferred over diuretics, because most of these patients will be already on diuretics and they will be having constantly contracted intravascular volume. So we are going to use diuretics, it has to be used very cautiously, or you can use other drugs with positive lusitropic effect. When you are using the drugs with the lusitropic effect, it's going to enhance the ventricular relaxation and it is going to reduce the left atrial pressure. So what are the pharmacological agents that's going to be helpful during this period? We start with dobutamine, which is commonly used everywhere. But remember, this lusitropic effect is only up to 5 mics per kg per minute. So in case if you are going to go above this dose, the lusitropic effect is lost. Or the nitroglycerin with the phenylephrine combination is another very good option, because the adverse effect or detrimental effect of each one is cancelled against each other when you are using them in the combination. Or if you are having milrinone or levosimendan also will be helpful when this patient develop diastolic heart failure. So coming to the most important aspect, unlike other conditions, the extubation and immediate postoperative period where there is a high risk for this patient to develop diastolic heart failure, because whatever stressful condition what we have discussed earlier is going to happen now. The patient is going to have severe tachycardia, maybe because of the pain or shivering, or the patient might have received a lot of fluid intravascularly and that would have caused intravascular volume expansion, or the patient might be coughing against the spontaneous inspiratory effort with the tube in place. All these things puts a loading condition very high. The patient might have the high preload or increased afterload because of the surgical stress, circulating catecholamines, and because of the increased blood pressure, and of course the development of any arrhythmias. So this is the extubation and immediate postoperative period is the most important or crucial vital period to look for, constantly monitor this patient for any signs of diastolic heart failure. So to summarize, Diastolic function is an active process and a major determinant for diastolic function. So, but it is often overlooked because these patients are asymptomatic at rest. But remember, they are going to decompensate under stressful conditions inside the operating room. So, echocardiograph evaluation needed to be done in high risk population to identify diastolic dysfunction. And management of the diastolic dysfunction rests mainly on good control of blood pressure, heart rate or rhythm, fluid status, and avoidance of marked swings in hemodynamics and volume. And severe diastolic dysfunction patients have very narrow window for fluid therapy, and hence judicial usage of fluid is advised. And remember, treating diastolic heart failure is more difficult than treating the systolic heart failure. So, because the pharmacological options are less, so always prevention is the best option.